Professor Kirit sir, good evening, sir.
Sir, good evening.
Good evening, sir. Thank you, sir, for introducing Dr. Bharadeshwar. Jyoti, you have any
Sir,
challenge in make it in full screen, ma? Gunabi sir, good evening.
oh, sir, so screen is visible now, sir. My
Can you make it
presentation
full screen? I'm asking Jyoti.
full screen.
You make it a screenshot.
Screen show. Okay.
Yes.
Okay,
You're
sir.
good to go. Just run through the slides. Just check all the slides are moving till the end.
Okay, sir.
Go till the end rapidly. Go. Yeah. Think you're okay. Ma. You're okay. All these things are still pictures only, no?
Yes, sir.
All right. All right. Go to the first slide. Give me 1 minute. I'll just inform the faculty to start. You just don't unshare Jyoti now. You are good to go. Don't do anything now. You are perfectly okay.
Okay, sir. Okay, sir.
Good evening,
Can I
Kanagaval
start,
sir.
sir?
Sir, good evening, sir. How are you, sir?
I'm fine, sir. Fine, fine. All the best,
Thank you,
Jyoti.
sir. Thank you. Thank you. Give me a minute, sir. I'm just set.
Yeah, yeah.
Yes.
Dr. Kamlesh, good evening.
Good evening, sir.
Good evening, sir.
Sahai, sir, good evening.
Good
Sir, good evening, sir. Dr. Parmar, good evening.
Yes, sir, good evening.
Yeah.
Hello, Jalal sir, good evening.
Good evening, sir.
evening, sir. Jalal, sir. Good evening.
Long time.
Dean, sir, good evening.
Good evening.
Good evening, or Sahai sir,
Good evening,
Kamlesh.
sir. Good evening, sir. Yes, yeah.
Yeah.
We
Good
met in
evening, sir.
Thrissur, sir.
Thank you, sir.
Good evening, friends. Warm welcome to all the faculty, invited faculty, and our own faculty. Dr. Gayatri and Dr. Rajvelu sir are joining shortly. Thanks to the good office of Dr. Kirit sir for introducing the faculty from NHL Medical College. Professor Kamlesh, welcome to this group.
Good evening, sir.
Good evening, sir. Gunabi sir, thank you very much for permitting your postgraduate to present a case here.
Always
Friends,
welcome, sir.
Gunabi sir is a professor of surgery at Assam Medical College. This is a very nature-centric place, very busy government medical college at Dibrugarh. So they have a huge endoscopy practice, laparoscopy practice, the very busy department at that local point, which has all the infrastructure in that northeast part of it. So thank you, Gunabi sir, for permitting your student to join today. I
Thank
also
you so much
thank
for the
Jalal
opportunity,
sir,
sir.
Sahai sir, and others who have joined today. And I wish both the student good luck. And then Dr. Jyoti, please introduce yourself and start your presentation. You'll be presenting without stop till the end of the history. And then you'll be revisited slide by the faculty. The same way clinical presentation will be haltless. Once these two things will technically get over in about half an hour time. Then
Yes.
we move on to the investigations, management, and a bit of complications. That's how it works. Good luck to you, Dr. Jyoti. Faculty, please take out.
Thank you, sir. Good evening, respected teachers. I am Dr. Jyoti Prasad Bhattacharya, a third-year PGT student at Assam Medical College and Hospital, Department of General Surgery. Today, I am presenting a case presentation on gastric outlet obstruction. My patient, Mr. X, a 33-year male, Hindu by religion, daily wage worker by occupation, hailing from Melang Tea Estate, Jorhat, admitted at Assam Medical College and Hospital on 10th of February 2026, and I examined the patient on 26th of February 2026. Coming to the shift complaints, the patient complains of pain in the upper abdomen since 2 years, fullness in the upper abdomen since 3 months, vomiting since 3 months. Coming to the history of present illness, patient complains of pain in the upper abdomen for last 2 years. It was insidious in onset, burning type, intermittent with diurnal variation, and later shows periodicity. Pain relieved after intake of food. For last 2 months, pain character changes to a dull aching pain mainly related to the fullness. There is no history of pain radiating to back. The patient complains of fullness in the upper abdomen since last 3 months. It was insidious in onset, gradually progressive in nature. Initially, the patient noticed a feeling of fullness after taking meal and occurring even and later on he noticed it occurring even on empty stomach or consuming a small quantity of meal. It aggravates after intake of solid and liquid meal and relieved after vomiting. He also complains of feeling of rolling mass in the upper abdomen after intake of meal which subside after vomiting. Patient complains of vomiting since last 3 months which is insidious in onset and is associated with food intake. Initially, it was intermittent in nature, 2 to 3 episodes per week, and gradually increases. And since last 2 weeks, frequency increased to 1 to 3 episodes per day. Vomitus was initially small in quantity. Now large volume vomitus occur 30 minutes to several hours after food intake. Vomiting is projectile, non-bilious, copious, contains undigested food particle, sour taste, and is occasionally foul-smelling. Vomiting is sometimes self-induced to relieve the fullness. There is no history of fresh blood in vomitus or coffee ground vomitus. There is history of significant weight loss, 5 to 6 kgs in the last 3 months with preserved appetite. No history of difficulty in swallowing, black tarry stool or yellowish discoloration of eyes and urine. No history of corrosive intake, steroid abuse, chronic cough or blood on coughing. Frequency of both micturition and bowel habits have decreased compared to the 3 months back. Sleep is disturbed, no history of any known comorbidities. Now he is NPO, nil par orally since admission. Coming to the history of past illness, patient had complaints of bloating, flatulence, heartburn in the past, for which he took proton pump inhibitors and NSH on and off without physician advice. No history of tuberculosis, asthma, COPD, no history of any surgery in the past. Coming to the family history, there are only 2 members in the family. All are enjoying good health. His parents died in old age without any serious illness. His siblings enjoying good health. There is no history of similar illness in the family. There is no history of any malignancy or malignancy associated death in any of the family members. Coming to the personal history, the patient takes an average rice-based non-vegetarian diet. He does not consume smoked food, preserved food, or a high salt diet. He is not an alcoholic. He uses betel nut and does not smoke or consume tobacco. Socioeconomic history. The patient belongs to a lower middle class family according to Bijay Prasad scale. He lives in a pakka house, consumes water from water supply by tea estate and uses a sanitary latrine. Immunization history. BCG scar is present, others not specified. Coming to the allergic history, not allergic to any known inhalant, ingestant, and contactant. Drug history, there is history of on and off PPI and NSH intake.
Yeah, Dr. Jyoti, let's go to your first slide. I'll just go through your history fast. First slide. First one, yeah. Next one, before that. Look, religion is not important until unless, just next slide, please.
Sir,
Next slide.
next slide, sir.
Yeah, religion is not important until unless there's a specific diseases related to that religion. You get me?
Sir,
You don't have to mention religion of a patient until unless it is related to your condition.
yes, sir.
Being a Hindu, does it help or does it aggravate his condition? It does not.
Yes, sir.
So it's not meant to be mentioned.
Okay, sir.
Date of admission and date of examination not required.
Okay, sir.
What do you want to convey?
When
Why
I
have you put
examine the patient, sir, actually I want to convey that only.
not required?
Hmm,
Yeah, next
okay,
slide.
sir.
Of these three, pain, fullness, and vomiting, which
Yes,
is the
sir.
most important symptom? You've got 2 years of pain,
Yes, sir.
right?
Yes, sir.
And fullness 3 months and vomiting 3 months.
3 months. Yes.
So which is more important here?
So mainly the vomiting part is more important if we are.
Yes.
Yes, sir.
So you should put vomiting above fullness. Since they're both of 3 months, vomiting should come more before
Okay, sir.
that. Okay, next slide. Next slide.
Okay.
Now, you have to describe the pain in terms of Socrates. Site, onset,
Hmm.
right?
Yes.
Character, radiation, aggravating factors, relieving factors, all that kind of
Yes.
thing. Okay.
Yes, sir.
So your pain history is not giving us anything except that it may not be pancreatitis because not relating to the back. But is it related to the vomiting? Does
Pain,
the pain
sir.
relieve on? Yeah. Does the
Sir,
pain relieve on vomiting?
sorry, actually, the pain character is initially not same with the present pain history, sir. Initially, it is
What is the
with starting, it is of burning type, sir. Then it is, sir, intermittent with, sir, diurnal variation. Then later on, periodicity
what do you
come
mean by
and
diurnal variation? It
yes, sir.
gets more at what time?
Sir, in the sir, early morning type, sir, 4 a.m., 5
So
a.m., sir.
staying, you said that relieved after taking intake of food.
Yes, sir.
So what kind of pain would be relieved by take in after intake of food?
Sir, usually, sir, duodenal ulcer pain, sir.
Right.
Yes, sir.
So what about this burning? What is diurnal variation? It gets more in the morning, early morning.
Yes, sir.
Now, does the pain disappear completely?
No, sir.
So you have to write that. No?
After 2 to 3 hours after food intake, the pain again comes, sir. That's why I had an intermittent, sir.
Okay.
Mm.
And is it related to vomiting?
No, initially there is no vomiting, sir. Now
No,
the
now. I mean now.
now the
When you
after vomiting, sir, the pain decreases because the
have you
present
written
pain,
that?
sir.
Yeah, just next slide, please. Have you written that? Because maybe I
No,
missed
sir.
something.
I think
No,
he's
sir.
written. I think I remember he's writing. The pain gets relieved after vomiting, and even he induces vomiting, something like that. You said no. He
Yes,
induces
sir.
sometimes vomiting to get. What is relieved? Is it the pain or the discomfort or fullness?
The
What is
fullness,
getting
sir.
relieved?
Fullness.
Yeah, so that you have to
Full.
make sure. It's
Actually,
not
sir,
the
that.
pain. No.
Yes, sir.
It's not
Yes.
the pain that is
Jyoti,
relieved. You said the fullness and the rolling something sensation that is relieved after vomiting, for which the patient induces the vomiting, isn't it?
Mm.
So
Yes,
the
So
sir.
that you have
what
to
you have
read.
written in the next slide.
Next slide. Yeah, all this is written. Next
Jyoti,
slide. Next slide.
can you explain me on the diurnal variation of the pain? What do you mean by that diurnal variation?
Sir, the pain is more during, sir, early morning time, sir. Like, sir, 4
No,
a.m., 5 a.m.
no. The next sentence you are saying pain relieves after taking food. So he takes food in the early morning.
No, sir, I written that in terms of, sir, relieving factor, sir.
No, normally that is not the word we use when we are describing the pain,
Okay,
whether
sir.
it is what is its relation.
Okay, sir.
And can you tell me
Okay,
why
sir.
the pain relieves after taking food?
Sir, because in cases of, sir, duodenal ulcer, the ulcer is exposed to the acid of the stomach, sir. So after food intake, there is, sir, the exposed
No,
area decrease and
you take
dilution,
the
sir.
food, will it reaches the duodenum immediately?
No, sir. Not immediately, sir.
Then how the pain is relieved? No, it is not that, see, when we are thinking in terms of gastric carcinoma,
Yes,
normally
sir.
we have achlorhydria. It is not due
Yes,
to the
sir.
pain, it's not due to acidity pain.
Yes,
But it
sir.
is always a mechanical pain when the food
Yes, sir.
reaches the duodenum after 3 to 4 hours of taking food. It
Okay,
is
sir.
in fact the pain, that is the time the bolus. In the gastric carcinoma, it produces immediately pain. But the
Okay,
food
sir.
to reach the duodenum, it takes 3 to 4 hours. So that time it reaches the bolus, reaches the duodenum, and it is going to produce. It is nothing to do with an acid here in that. And you are also
Okay, sir.
saying there is a periodicity. How do you elicit the periodicity here? Still the
Sir?
patient has periodicity. Periodicity.
Okay, sir. Periodicity, sir, develops later on because of the healing process of the ulcer. And then again, sir, ulcer active healing, that
So
phases.
now, are you dealing with an active duodenal ulcer, benign or malignant? When the periodicity denotes it is a benign condition or a malignant condition.
The benign condition, sir.
So you are dealing with a case of a benign condition.
Benign conditions.
Okay. Oh.
So periodicity means what? Can you a little more explain?
Sir.
What is periodicity?
Sir, there is, sir, a fixed interval of time which in that interval the patient is symptom free, sir.
Yes, totally
Then
symptom
again,
free, and then again it comes back. It goes
again
on,
comes.
isn't it? It goes on like that. Okay. In
What is
between,
the
patient may
reason?
get pain.
What is the
Reason for that? Yes.
Yes, sir.
It is not that wound is healing and something is happening, but is it something to do with the periodicity of the winter, summer, and autumn? That is the period of the climate. Any relations with that?
Yes, sir. In
So
winter,
it is a long drawn process. It is not that you are going to make it within a 1 year, you are going to make a periodicity. So there is a
okay, sir.
long process, when you have the histories for 5 years, 6 years, then you can be able
sir.
to elicit that. Otherwise, it is very
Okay.
difficult. One of the
Okay,
hallmark
sir.
is loss of periodicity, we are going to say. But your case is little confusing on that.
Yes. I think I was also want to say there's a lot of cross-connecting histories there. Next, can you show the next slide? What is in the next slide?
What,
So
sir?
many things. Next slide.
Uh-huh.
Go to the
Not
next
okay.
slide, please.
Next slide, sir. Okay, sir.
Insidious and on gradually progressive. Okay.
So all the pain, the original pain is also insidious in onset. This is also insidious in onset. What do you mean by the insidious in onset?
Sir, in insidious in onset means, sir, it is during that period, sir, patient is well only, and it is starts, sir.
No, you were saying the last 2 years the pain is there, which is also insidious in onset.
Yes,
Now
sir.
again the 3 months also, that is again insidious in onset.
Yes, sir.
And there is a fourth sentence is written: the pain is aggravated after intake of solid food and liquid meal and relieved after vomiting. That's the thing. So what do you mean by that? It aggravates after intake of solid and liquid meal and relieved after vomiting. What is aggravated? What do you mean by that?
Sir, the fullness, sir, it actually fullness increase. There is already a fullness that is present even without taking the meal, but on taking the meal, the fullness increases, sir, and that is relieved after vomiting, sir.
No, will you say the fullness is relieved?
Fullness.
No.
It decreases actually, sir. Not totally relief, sir.
So he's also complaining of rolling sensation in the upper abdomen. What does it indicate? Rolling sensation in the upper abdomen.
Sir, in this case, sir, it may indicate that peristalsis, sir.
Okay.
Gastric peristalsis, sir.
Which subsides after vomiting. Okay, fine. Next slide. Again, the same thing is repeating. Intermittent nature.
Please be careful in using the word insidious. It is not the word which has to be used routinely for everything.
Okay, sir.
Yeah.
Dr. Jyoti,
something is happening with a harmful intent.
Okay, sir.
Without your knowledge, it's happening.
Okay, sir.
So
I have a question.
For everything, if you are not using the insidious, then we are totally now confused with that and what you are now trying to come out that.
Okay, sir.
Dr. Jyoti, as per your history, for 20 months, patient had a burning pain, and since last 2 months, he is having the lacking pain. Now, for last 2 months, what your detail mention is regarding the fullness of the stomach and how.
Sorry, sir, not audible, sir. Repeat, sir.
Just a minute. Now can you hear? Hello? Hello? Hello?
We are able to hear you, sir, but
Yeah,
Yeah,
Jyoti,
we
okay.
are able to hear. Only
Yeah.
Jyoti, can you hear him?
Hello, Jyoti, can you hear me? Hello?
Jyoti, can you hear us? Hello?
Hello, Jyoti?
Is he not hearing in?
He is not
Uh,
hearing.
something wrong with your connection.
Your connection.
Kamlesh sir voice we are hearing.
So some problem from Jyoti side. Hello, Jyoti?
Hello, can you hear me, sir?
yes, 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 yes. We can hear
Okay,
you.
okay. Yes.
How can we unhear Gayatri madam?
Sir, so long I was not able to.
JP, can you hear us?
Jyoti?
I think he's just left. He will come back. Maybe it's trying. Jyoti, can you hear us now?
Okay.
Okay.
So my point is that for first 20 months of your history given was a burning pain, which was get relieved by early morning food intake. Okay. And for last 2 months, you told that he is saying lacking pain. At the same time, fullness was there also for last 3 months. Now you narrated detail regarding the fullness and how it gets relieved, but there is no mentioning regarding the how the pain was getting aggravated and relieved for last 2 to 3 months. You mentioned details regarding the fullness, but we are missing the details regarding the relief of the lacking pain and aggravation of that pain.
Actually, sir, regarding the non-aching pain, sir, I actually mentioned it like that for last 2 months, patient is having a non-aching pain that is related to fullness, sir.
ஏங்க கேட்கவே இல்ல எது வாட்டியோ என்ன
And Jyoti, you have mentioned it's a undigested food particles in the vomiting. And where do you think the obstruction could be then, if it is undigested food particle?
கேட்கலையே
It indicates that, sir, food is not reaching the small bowel, sir.
It cannot
No.
be. If it is, see,
That cannot
stomach
be.
is always a pulverizing. Anything reaches the stomach, it will become a partially digested food particle.
என்னோடது எதுவுமே
If
வர
you are
சொல்லு.
saying it is undigested food particle, that always denotes your obstruction is at the OG junction. Food is not entering into the stomach.
And
Here
if it is
you
OG
said
junction obstruction, one second, sir. OG junction, you cannot use the word of vomiting also. What is vomiting?
Yes,
So,
it is
and
regurgitation, sir.
undigested food particles can only regurgitate. So esophageal symptoms
sir.
are typically said as regurgitation, and vomiting is
Regurgitation,
always
sir.
from stomach. And was
Stomach,
Jailal sir correctly mentioned, it cannot be undigested. It will be partially digested.
Okay, sir. Okay, sir.
why
Okay.
it is foul smelling?
Sir, foul smelling is, sir, if the vomiting is within 50 to 60 minutes of the food intake, sir, then usually it is not foul smelling, sir, because of the acid content of the stomach, sir.
Do you think our food will get decay within 60 minutes?
Sir?
Do you think the food will get decayed within 60 minutes?
No, sir.
Huh.
So within 50 to 60 minutes, immediately after the...
Doctor, you are right in saying foul smelling. That is
Yes,
a
sir.
typical feature of the gastric outlet obstruction. But what is the reason?
The decline of contamination, sir.
Because there is a
So
lot of stasis of the food will be there.
What is the time limit of the vomiting? That's what, sir. That if you can address that, the decay and the foul smelling can be explained. It's not always 30 minutes or 1 hour.
Yes, sir.
What is the time limit of vomiting after a food intake? What is the character of the stomach? Will the patient vomit every time 30 minutes after food intake, or sometimes
No,
very late?
Sometimes, sir, several hours after meal, sir.
Yes, exactly. The stomach is like a bladder. No, it can accommodate a lot of food. Sometimes patient will take 2, 3, 4 meals, and patient may vomit next day or next day.
Yes, sir.
So that's what that will explain. When a patient has a lot of stasis and patient is partly digested, it will be foul smelling, large quantity patient will vomit and patient will get relief. Okay.
Yes, sir.
Along with the rolling sensation and all.
Yes, sir.
Dr. Bhattacharya.
Yes, sir.
Hello.
Yes,
Yeah,
sir.
I have a question for you. Did you ask whether there was staining of the floor on vomiters?
Yes, sir.
There was, or
Yes,
there
sir.
wasn't?
Yes, sir. There are staining of the floor on vomiters, sir.
So what does that tell you?
that is that enough of acid is still secreting in the stomach, sir. It is
So it
the
is, there
vomitus
is acid there,
contain the acid, sir. Acid is there, sir.
right? So that rules out malignancy,
Malignancy, yes, sir.
right? Now, also the food will, the stomach contents will be foul smelling. If there is no acid, then the bacteria
sir.
grows,
Yes, sir.
and uh, there is
Your audio is getting
and there
broken.
is smell, right? So the when there is no acid,
Yes, sir.
the bacteria grows,
Yes,
and
sir.
that helps, that brings about foul smelling
Foul
vomitus,
smelling, sir.
right?
Yes.
Where do you get a fresh blood in vomitus?
Fresh blood, sir. In case of some active bleeding, bleeding testicles, sir, also bleeding varices, we can get some fresh blood, sir.
From where? The blood comes from where?
Comes from stomach, sir.
Okay. Stomach, you can get a fresh blood.
Esophageal varices also gets fresh blood, sir. Stomach, if it is bleeding, then we may get some.
No, why you are mentioning the two things? No fresh blood or coffee ground vomitus. What is that you are looking for?
Coffee ground vomitus is concerned if there is minimal bleeding going on in the stomach, sir, from inside surface, or if there is a growth from the root surface, sir, then you can oxidations can happen and they form some iron sulfide, and that will form the coffee ground, sir.
You need to check your audio.
Audio is not good, Jyoti. We are not hearing you properly. Something's
Okay,
wrong
sir.
with your audio. We are not
Yes,
hearing
audio
you
is
properly.
not clear.
Hello, sir. I'm audible, sir. Now, sir.
You are audible. We are not. You are not able to hear you properly.
Okay, sir.
Going with Jalal sir's question about the fresh blood, can you get fresh blood from stomach? The answer is if the large quantity comes out in short span of time, you can get a fresh blood. Okay, as you correctly mentioned, small quantity blood, if it stays there and acts upon by the bacteria, this acid, it will get altered, and that's the answer. Sometimes even if upper GI bleeding, even you can get fresh bleeding per rectum. Sometimes with large quantity bleeding, blood clots, and yeah, I can get. That's all depends on how the transit time and how much blood is lost. Good time. Okay. Yeah.
That whenever you put any words, you must be able to explain that why you are putting that.
Yes.
Yes, sir.
Next slide. We'll go to the examination, I think. Okay. No history of lactate stool. Okay, so there is no history of any bleeding, isn't it? No. What corrosive history will get a gastric outlet obstruction? Corrosive intake. What a corrosion will get gastric outlet obstruction?
Weak acids are more likely to.
What?
Weak acids, sir. Weak acids.
Acids.
Weak acids, sir.
What happens if we ingest alkali? See, alkali basically produces esophageal spasm and produces liquefacting necrosis of the esophagus. So there is an old saying like acid licks the esophagus and kicks the stomach.
Yes, sir.
Acid licks the esophagus and kicks the stomach. It will produce pyloric spasm and produce more stricture and fibrosis of the pylorus, and can produce a long-term complication like gastric outlet obstruction. Okay, acid. Alkali mainly produces esophageal injury. Okay, yeah. Steroid abuse. What can happen with steroid abuse? Abuse means what? Steroid abuse. What do you mean steroid abuse? I don't know. Bodybuilding. You mean bodybuilding steroid or something like that?
Sir, long-term steroid abuse over time, sir.
No. Sir is asking, what do you mean by steroid abuse?
Abuse.
Excess usage is different. Abuse is something which you do for your own personal satisfaction. Something you are
yes. Without any medical indication, that's abuse. No, use or abuse. Yeah. Chronic cough of blood and coughing. So what do you mean by what you are looking at blood on coughing in this case?
Sir, we will try to rule out for tuberculosis.
Tuberculosis. Okay, tuberculosis can rarely produce. Okay, right.
Yes, sir.
Okay, next slide.
What is your inference from the history?
Yeah, history, what do you think?
From the history, sir, it is looking like a case of gastric outlet obstruction, and from the history, it is mainly sir look like sir related to chronic gastric ulcer disease, sir.
Age
No,
of the patient, I forgot the age. What is the age of the patient?
35, I think.
35.
35, sir.
Okay.
35.
if you not talked about early satiety, you knocked about then how is his appetite and whether it is good, any change in
Appetite,
that.
I mentioned, sir. Appetite, I mentioned, sir.
I think
There
I
is
mentioned about early satiety.
uh, appetite, sir. I mentioned there is history of significant weight loss in last 3 months with preserved
No,
appetite.
significant weight loss is there, pa. What is
It is-
appetite and what is the satiety is there? What is
Is
happening
it
in that?
preserved appetite is written.
Satiety, actually, sir, I didn't mention because already I have mentioned about the fullness, sir. Meal, sir. Fullness, I already mentioned, sir.
No,
That's why.
fullness is a different feeling, pa. Even if I take 2 biryani, I
Yes,
will
sir.
feel the fullness.
Hmm.
The fullness can be there in a different way. You said that it's initially the fullness will be there, then later it for the small food the fullness comes.
Small
That is
food
not
can
the
be
early
there, sir.
satiety which we are talking about. What do you
what
mean
is
by early satiety? Why
what is
do
the
you get
reason?
early satiety?
Why do you get? Yes.
Early satiety, sir, with the feeling
Due
of
to the receptive loss of the relaxation. So, and the stomach cannot fill in. It will be there.
Yes,
So,
sir.
you will not, when there is early satiety, it is not going to produce a big fullness. You are not going to take anything inside. Or something else, the mass is going to compress on that. So, whenever you are going to talk about the CA stomach or the stomach, these two are very important, appetite and early satiety.
Early satiety, sir. Yes.
Loss of appetite is different, actually, not compared to both are different entities. As sir correctly mentioned, the distension of stomach, distensibility of stomach is lost, we get early satiety because, like typically in diffuse carcinomas or anything like
Yes,
pseudocysts,
sir.
anything compressing from outside, stomach cannot
Compressing
distend.
from
That's
outside.
as simple as that.
Yes, sir. Yes, sir.
Loss of appetite is due to so many conditions, maybe early malignancies or late
Yes, sir.
malignancy, or so many other non-malignant conditions like even in appendicitis, chronic acute pancreatitis, all these you get appetite
Yes, sir.
loss. Even in viral fever, you may get. Okay,
Yes, sir.
so that is the thing.
Lot of other conditions can
Lot of
produce.
conditions.
But
Yes.
what I feel is that you are putting a lot of things into these cases. Your presentation and words are very good. But only thing it is little confusion is there. It is not coinciding with what you wanted to convey.
Yes, sir. Yes, sir. Yes.
Okay.
I get it, sir. Yes.
Okay.
We all
But
thought it is malignant, and you're trying to say it is benign. You're trying to put all benign things there. You talk about early satiety, then you say he has got what is that? A weight loss. Then you say the pain subsides after he takes food.
And the nature of the pain is dull aching.
lot of things. Lot of things.
Well,
So, yeah.
maybe
How often is the duodenal stenosis producing gastric outlet obstruction these days? How frequent it is these days? Do you see it as much as some 20, 30 years back?
Yes, sir. After the PPI and HPK use, sir, it is decreases, sir.
Very much
Significantly.
decreased. I don't know.
Yes, sir.
Ulcer seen in
No,
the
it is
last 10 years.
very less. And your patient age group is only 35, no?
35.
33,
It's too
sir,
early.
33.
To get a duodenal ulcer obstruction, it takes long
Yes,
time.
long time.
He has to earn that disease.
Yes, sir.
We haven't seen for many years actually. It's very rare now because, as you correctly put it, people whenever there is an upper GI symptom, they all take PPI and the ulcer will be healed. Okay, whatever.
Yes, sir.
We, even without diagnosis, they take drugs. So complications related as such with the duodenal ulcer are reduced. Even perforation,
Yes, sir.
duodenal stenosis, all these are very, very rare. Okay. The most common cause of gastric outlet obstruction in our situation, what is the most common cause of GU?
Carcinoma stomachs.
Malignancy. By far
Yes.
the most common. Maybe 80%
Yes.
of the GU are due to malignancy, antral malignancy. Others are all forms very small. Okay. So you want to put it as benign, right?
Yes, sir.
Because of why you want to put it as benign?
Because, sir, there is actually, sir, the history part is difficult to say. Till now, I'm not going to the examination part, sir. But to the history part, sir, the appetite is totally preserved The significant weight loss only present in a case of peptic ulcer disease if there is gastric obstruction, sir. There is, sir, no history of any stool or any hematemesis also, sir. And sir, there is a proper history of the peptic ulcer symptoms, sir, from last 2 years with the patient, sir.
Okay, you always
Mm.
keep your mind open for another differential diagnosis.
sir, yes,
Okay,
sir. Yes, sir,
let's go to examination. No, sir, we'll go to examination.
Yes, yes, yes.
Okay, go to examination.
In the general examination part, patient is alert, conscious, cooperative, well-oriented to time, place, and person. Appearance looks ill, decubitus of choice, weight is average, nutrition is poor, BMI 18 kg per meter square. On ECOG score, the patient ECOG score is 2, pallor present, dehydration present, icterus, cyanosis, and edema absent. Coming to the examination of oral cavity, lips, dry mucous membrane, teeth stain, gum stain, tongue dry, papilla present and pale. Neck veins not engaged, neck veins not palpable. For the pulse rate, 67 per minute, regular in rhythm, normal volume, no radioradial and radiofemoral delay, peripheral pulses are palpable and bilaterally symmetrical. Sir, 130 by 80 millimeter mercury in right upper arm in supine position. Temperature is 98.5 degrees Fahrenheit. Respiratory rate 17 per minute, regular abdominal pressure. Nails, no clubbing or koilonychia seen. Skin and hair, loss of skin color. Hair appears normal. Lean spine, no skeletal deformities. The systemic examination, abdominal examination.
Coming to the general examination,
Okay,
we'll
sir.
finish that but by one. You said the teeth and the stained. He's not a smoker. He's not in any.
Tobacco, sir. It takes this betel nut, sir. He consumes betel nut, sir.
Stained with the betel nut.
Yes, sir.
Which what are the parts it is staining? Betel nut?
What, sir?
No, what are the areas the betel nut will stain?
Sir, that's our teeth, sir. Then the retrolateral trigon part, sir. Then mucous membrane also stains, sir.
It's
See,
very,
Arm
very
also,
rare
sir.
for the teeth to be stained
Mm.
when somebody is taking a betel nut. Okay.
Jyoti, if you look at this slide, we are again more confused.
Yeah, much more confused now.
You are more confused now. Whether you said is benign, now you look at this slide. Patient looks ill, nutrition is poor, built to the average ECOG score you mentioned, BMI is very low, pallor is present, dehydration present. With all these, edema is also edema absent. Okay, sorry. So this slide is again you are confusing us. Now we were going in one direction of benign. Now this, if you look at this,
Your presentation of history and this general examination is totally not relevant, correlating.
or not correlate. This looks like a malignant patient. If you look at this slide, it's of a picture of a malignancy. Okay, anyway, go to the
Why
next
should
slide.
a duodenal ulcer patient look too ill?
And also loss of weight is there. Pallor is there. Pallor is also present, you mentioned.
Also, when did the patient get admitted? Date of admission and date of examination. You mentioned in the first slide.
Yes, sir. Yes, ma'am.
Yes. How
Yes, ma'am.
how long after the patient got admitted you examined the patient? This one, this presentation.
16 days back. 10th he is admitted. 26. I
Since
remember.
the
I have
patient was
written it.
dehydrated, even after all your treatment, yes, you must have initiated, no?
Yes, ma'am.
IV fluids at least.
Actually, ma'am, this mistake from my side, ma'am. I
So
examined
that
the
is why,
patient
that is the
previously,
importance of
ma'am.
date of admission and date of
Yes.
examination.
Yes, ma'am.
If you
Yes.
have given 10 or
Yeah.
15 days after admission,
Yes.
then his dehydration at least should have got
Yes, ma'am.
corrected, no?
Yes, ma'am. Definitely.
But
These
all
days
your
is very
findings are
important,
there
Jyoti.
for
It's very, very,
dehydration.
yeah.
Skin turgor is lost. What do you mean by ECOG 2?
Sir, COG2 is, sir, that is, patient is with difficulty, he is doing the day-to-day work, sir. With difficulty, sir.
ECOG 2 is a very, very patient is going to be a sick patient. You are not, he is
He-
not going to do any,
he-
but that
he
is not the
said-
way you have started presenting.
Yeah, he is a 35-year-old man, otherwise fit. That's what we thought. Now patient's ill, ECOG is only is a 2, BMI is very on the lower side, pallor is there, dehydration is there, all this. Okay, so
Repeatedly, I asked that question. By 18 kg per meter square means what?
And for benign pathology, you will not put ECOG there. Okay, if you have to give the performance status, you can give it by the Karnofsky. But ECOG is especially for the malignancy only. जो है ना?
what is the full form of ECOG, Jyoti Prasad? Eastern Council Oncology Group. That's what Sir is saying. So oncology group. That's what he said. You should use it only. Eastern Council Oncology Group. Okay, so the oncology only. Yeah, it's basically for malignancy. Right. Okay. Next slide.
And patient is pallor, but you are right saying that no koilonychia, no. What do you, is it? Anything else? The pallor will have a change in the nail.
Nail.
What is platynychia? What are the stages that nail changes takes place in anemia? Because you wanted to express what you know. In the examination of the PG, that is not that what we are intent to see. We want to see you observe the patient and say what is there.
Yes.
We don't want you to come and say that straight away you are looking for a koilonychia.
Yes, sir.
And Jyoti, one more point I'll tell you. Whatever you mention in your history and examination, you are going to raise a question on that. If you don't know, it's better not to mention. If you written here where neck veins not engorged, why you want to write an engorged? Why do you expect an engorged vein in this case? You expecting engorged veins?
No, sir.
So why do you
So
write that?
tailor your examination also. Not all cases need all.
The neck veins is not relevant in this case. Engorged. Why? Where do you get engorged veins in neck veins? Why do you? Is it cardiac failure? Is it cardiac tamponade or tension pneumothorax we are dealing with?
Yes, sir.
No, we are not. We are dealing with a gastric, or you don't. Or maybe dehydration. If at all it is there, maybe the neck veins, everything will be collapsed. Maybe completely dehydrated patient. So you don't. There's no significance for the engorgement at all. So don't write all those. Okay.
Which papillae you see on the tongue? What are the different types of papillae will be there in the tongue?
Circumflex papilla, sir.
So which papillae you are seeing here?
Mainly to, sir, in the you're seeing the circumflex papilla.
What does it indicate?
So, sir, loss of papilla and all indicates, sir, vitamin deficiency, sir.
No, your tongue is dry and pale. We talk about the glossitis or the pale. That is, but you are saying the papillae is present. Then you ask whether it's a hairy papillae.
You want to convey dehydration probably, isn't it?
Yes, sir.
Okay.
Dry I mentioned for dehydration only.
That's why again they don't write unnecessary information. We are putting in too many things which you have no explanation.
Okay.
That will be a trouble in the exam. Okay. Neck glands. What do you mean by neck glands not palpable?
Thyroid and submandibular glands.
Salivary and all those. Submandibular. What do you mean by neck glands? What do you wanted to convey? Lymph nodes.
Are you talking about cervical lymphadenopathy?
Lymphadenopathy, no?
Yes, sir. Yes,
no,
sir.
sir. Generalized lymphadenopathy. You should put it like
Yes,
no generalized lymphadenopathy.
Okay, sir.
Don't say neck glands not palpable. Glands, not
We are
glands.
dealing with the stomach. Where do you want to look for the neck glands? Neck lymph node?
Left supraclavicular fossa.
No, that
Left
will come.
supraclavicular fossa.
That will
Do
come
you
as local
specifically
examination.
mention about left supraclavicular, not just neck glands? If you want to mention about left supraclavicular.
Okay, ma'am.
Suppose this patient is having generalized lymphadenopathy, axillary neck nodes. A lot of nodes are palpable. Can you have any idea? Can you correlate it to your diagnosis somehow? Will you change your diagnosis to some extent?
There may be, sir, gastric lymphoma.
Lymphoma, yes, correct.
Yes, sir.
That's
Good.
important for
What
examining.
lymphoma?
What type of lymphoma you get in stomach?
Will your gastric lymphoma produce neck nodes?
No, sir. According to the primary gastric lymphoma, sir, doesn't produce, sir.
Okay, very good. Dawson criteria, you have a
Dawson
criteria
criteria.
for that.
Primary
Yes.
primary GI lymphoma will not produce neck nodes, but
Yes.
this could be a
Yes, sir.
part of generalized lymphoma.
Yes, sir.
That
Yes, sir.
primary GI lymphoma, sir mentioned Dawson's criteria, correct?
Dawson's criteria.
But sometimes this could be due to generalized lymphoma.
Generalized.
I can have also like.
What is the definition of generalized lymphadenopathy?
Sir, more than two, sir, lymphoma within more than two continuous sites, sir. Presence of
Contiguous.
contiguous sites.
It must be a contiguous lymph node.
More than two, sir.
That means the neck node level 1 and level 2 are involved. That is generalized lymphadenopathy.
Generalized lymphadenopathy.
So, Jyoti, you are doing very well, but
Don't
I
worry, you are
wish-
okay.
But what we want, we are like the higher end parts you are putting. The basic things you need to little more concentrate. Okay.
Yes. Yes, sir.
Okay. Go ahead. Go ahead.
Next line. Go ahead. Go ahead. Okay.
There are
Okay.
nice things, Jyoti, but the thing is, unwanted things are there, and when we ask you, you're not able to answer. That's why.
Why do
Wanted ones, you just explain. That's all.
how do you check for radial delay?
I will simultaneously see the pulse on both the hands. Sir.
How much delay is permissible? And when will you say significant radial delay? And what is the cause for radial delay?
Radial delay, sir, mainly from subclavian artery stenosis, sir, or sir, arteritis also we may get, sir, radial delay, sir, and aortic dissection also we may get, sir.
Remember, we are going to give only 35 to 40 minutes for examination.
Yes, sir.
So in that, don't spend much of time on our general examination, which is not necessary. Radiofemoral delay or radial delay,
Yes,
which
sir.
is not related to your
See,
case.
you are dealing with a gastric outlet obstruction. Do you expect radial delay? Don't
No, sir.
accept. So, sir is
Only-
correctly mentioning, don't mention things which are not necessary. And whenever you mention anything, you should have an answer. Okay. You can say easily, if you why you look for, you should have an answer. That's all.
Yes, sir.
Okay.
Mhm.
Yeah, proceed. Whatever next slide. Okay, fine. That means there is.
Slide.
Okay, next slide. Okay, continue.
Systemic examination, abdominal examination. On inspection, the abdomen is neither stiffened nor distended. Fullness involving epithelium, low hypochondria, extending beyond umbilical region. Umbilicus is inverted in normal position. Visible gastric response is seen in the upper abdomen, which moves from left hypochondrium to mid epithelium. Skin over the abdomen is normal. No pigmentation or angular stain or visible pulsation seen. All quadrants move symmetrically with respiration. No fullness in flanks. Hernial sites are normal with no impulse on cuffing. External genitalia are normal. Coming to palpation, on superficial palpation, no local range of temperature, no superficial tenderness, no superficial palpable lump. On palpation, the upper abdominal fullness found on inspection tends to slip away from the examining fingers. No guarding or rigidity. On deep palpation, tenderness absent, no mass or lump were felt, succussions plus present, liver and spleen not palpable. Coming to the percussion part, tympanic node heard all over abdomen, shifting dullness absent. Ausculto percussion, rectal confession of stomach defined at 2 cm below the umbilicus. Auscultation, normal bowel sounds heard. Rectal examination, no abnormality detected. Normal, mucosa film normal, finger stain, stool stain. Coming to the other system, central nervous system, patient is conscious, alert, cooperative, patient is oriented to time, place, and person. His speech is normal and memory is intact. Pineal nerves are intact, motor system normal, reflexes and nerves are normal. Our respiratory system, in inspection, shape and size of chest is normal, movement of chest is bilaterally symmetrical, palpation, trachea is in the midline, chest expansion is normal, focal femmitus is bilaterally symmetrical and normal, percussion, long field is uniformly resonant in all areas, auscultation, normal vesicular beat sounds are heard and no additional sounds, focal resonance is normal on both sides. Cardiovascular system inspection, precordium is normal, no bulging is visible, pulses are seen. Palpation, apex beat is fell in the fifth intercostal space, thus medial to the particular line. Auscultation, first and second heart sounds are heard normally. No additional heart sounds heard. Coming to the summary, 33-year male with complaints of fullness of abdomen and with vomiting and pain abdomen. Vomiting is projectile in nature, containing undigested food, sour in taste, with pain abdomen, which is initially burning in nature, then food intake, usually become periodic and then become dilating related to fullness of abdomen and constipation. There is a feeling of rolling mass by patient moves from left to right, mainly following meal and relieved on vomiting. He also complains of significant weight loss with preserved appetite. On examination, he is dehydrated, anemic, ill looking, and there is visible gastric peristalsis which moved from left to right. No mass was felt per abdomen, but Sakason's plus is present, and auscultopercussion shows greater compression of the stomach 2 centimeters below the umbilicus. Patient is provisionally diagnosed to be a case of gastric ulcer destruction due to chronic peptic ulcer disease causing pyloric stenosis.
Okay,
Kamalesh
Jyoti,
sir, Kamalesh sir, you are the main faculty today. So you can ask your questions, sir, please.
I think there is so much narration of respiratory system, cardiovascular system, which is actually not required in this case.
Okay, sir.
Okay, that you can always omit. You can simply say
Okay, sir.
both systems are normal.
Absolutely, you are now stretching beyond your limit of what you can present.
Pericardium and all he has mentioned.
I think he is a physician or what? I think taking medicine also.
He is more interested in medicine.
He's more of a medical man. See, Jyoti, I think there were few points I mentioned. You said that there is a swelling in the left hypochondrium, isn't it? What do you mean? This swelling is what due to distended stomach? What do you mean? Isn't it? You mean the stomach only, no?
Diffuse fullness, sir. No, diffuse fullness involving epigastrium, left hypochondrium that extend beyond the umbilical regions.
Okay, left hypochondrium. Will you get the stomach to be distended in the left hypochondrium? I don't think the stomach will go to left hypochondrium.
Can you tell the boundaries of the left hypochondrium?
Yeah, where is left hypochondrium?
Sir, left hypochondrium, sir, it is between, sir, the ones.
So the easy thing to remember is the midclavicular line. It is lateral to the midclavicular line. It is lateral to the midclavicular line. So do you think the stomach will go there? However, the stomach, what is the direction of stomach distension? If the stomach is dilated at all, it will not go to the left side. It will go to downwards and maybe slightly towards the right side. So left hypochondrium is almost never involved in. However big, it will go down. The stomach will go, as you correctly put it, stomach is below the umbilicus, isn't it? That's how it is.
And never go on saying negative things. If you say abdomen is normal, it will be much better than saying that it is neither scaphoid
Flat,
nor
at
distended.
least. Abdomen flat.
Shape of the abdomen is normal, that you can say. You should know what is normal. That's all.
When will you get a scaphoid abdomen?
Abdomens are in cachectic individuals, we may get, sir.
Which one?
Cachectic individuals, sir.
Cachectic, okay, cachectic.
That is an extreme form. Any pathological condition?
Yes,
Can you get in when there is a diaphragmatic hernia is there?
Yes, sir.
So don't try to bring that what you know and to impress upon us, and that will not happen. That will only go in.
You can never impress upon jail ulcer, isn't it?
No, not like that, sir. I'm saying generally examination.
Yeah, correct. What you say is right. So how did you examine the succussion splash BGP? You mentioned BGP and succussion splash. Tell us, how did you examine for that? visible gastric
Sir,
peristalsis?
since like visible peristalsis, we go to the foot end of the patient, sir, and we firstly, to sir, we expose the patient from mid chest to mid thigh. Then, sir, we go to the full end of the patient, and then our eye levels would be with the abdomen level.
Okay, you inspected, it is not visible. Patient is not very clearly visible. What do you do?
Sir. Then we may ask the patient to drink
Drink.
amount of
So,
water, sir.
Okay, you will
test,
get.
which
So you
test
got
you have
it.
done first? Succession flash or VGP?
No, VGP. He is doing VGP. He has asked the
Yes, sir.
patient to drink water and is visible.
Yes, sir.
Now, how will you check the VGP succession splash? You made the patient drink 1 glass of water. You are happy. VGPs come very happy. So now
First,
you
we
want
have to check for succussion flush, sir.
That's
Because
what.
patient has to be impure for
What is the
4 hours.
significant succession splash? When will you get to say that succession splash is significant? Any patient you do succession splash, you get a splash, is it significant?
What are
No, sir.
the histories you will ask before doing the succession flash?
At least, sir, 4 hours nil par already is necessary, sir.
Yeah.
4 hours nil par already is necessary.
Minimum 4 to 5
4
hours.
hours.
Okay, yeah. Then only it is significant. Otherwise, any patient drinks
Yes,
water.
sir.
So always do the succession splash part first. Then only
Then,
look
sir.
for the VGP.
Yes, sir.
Otherwise, you can't check that, right?
Yes, sir.
Jyoti, you have mentioned that the lateral border of stomach you are able to delineate on oscultopercussis.
What will happen to
How
that?
does it contribute to your findings for your diagnosis?
Sir, usually in cases of gastric outlet obstruction, if it is due to a malignant disease, sir, then due to the distension is not so much compared to, sir, the benign disease, sir. Usually in benign disease, the distension is more, sir, and we get the lateral border usually below the umbilicus, sir.
No, that's not the
Not
answer.
always correct. Not always correct.
If the sir malignancies are involved the stomach walls, sir, infiltrated into the stomach walls.
So you will have stomach wall.
Diffuse type of cancers, you may not get the distant stability. Other cancers, isolated pyloric cancer, you will get distant stability.
You will still get that. When the muscle is not infiltrated, you will get it.
Early carcinomas confined to only the antrum.
And here there is, according to you, there is no mass. So what is that obstructing there?
That's why
that you can, if there's UVO producing such a obstruction with the benign condition, definitely on the right side, on the midline right side, you may feel the mass, the pyloric cap you will feel. But here you are saying nothing mass is felt. And what is happening this gastric pressure? It starts from left, comes to right, then what happens to it?
sir, it comes from left to right, sir, but due to, sir, such distension of the stomach, sir, we may not appreciate the continuous movements, and the next wave will come before that, sir, because of the.
No, sir, I mean, we are not able to fully, I'm not sure this where is the fault, but we are not able to fully comprehend what you are saying. Your mic or something is you have to adjust.
The audio is too poor. I don't know whether you people are able to hear me. I'm not able to understand what he's talking only.
Clarity is not there. We are not getting clear voice.
What is the reason for the visible gastric peristalsis? The stomach is trying to overcome the obstruction by increasing the peristaltic volume, isn't it? Amplitude, isn't it?
Yeah.
When will you get the right to left? Will you ever expect to get the right to left peristalsis in the upper abdomen? Ever?
Yes, sir, in any splenic flexor growth, sir, or sir, we may get, sir.
Colony growth obstruction.
Yes, yes, sir.
Okay. So here there is a hugely dilated stomach with VGP, succession splash, everything is there. So gastric outlet obstruction, dehydrated, patient is dehydrated. True, but only thing is about the pathology. What is the pathology? Whether you are saying is benign, and there is a lot of overlapping findings over malignancy also in your.
I doubt, because you said the stomach is felt below the umbilicus. But now you are saying the mass is moving towards the mid-epigastrium. Epigastrium is a small area above the pyloric plane, but the stomach is extended up to lower end. And are you not seeing that in the umbilicus region?
Yes, sir.
How do you say it is only in the mid-epigastrium?
Yes, sir.
Direction of the peripheral system.
You just stop with the left to right. And if you write left hypochondrium, see, what is that left hypochondrium and epigastrium on the straight line? The central portion is epigastrium. That is a. So is it going to try in a straight line? That
No, sir.
Stomach will almost never come to left hypochondrium. Remember that. Epigastrium may make it downwards. Okay. Right side also rarely. Right hypochondrium also it may not come sometimes because basically the central part of the stomach, part of the body, however dilates, it goes basically downwards. Okay. So don't say.
Okay.
Okay. Super. So that's the thing. Okay. Now this is the diagnosis. Can we go to investigation now?
Yes.
Somebody saying something?
I think it's a Rajavel sound.
Palpation also deep palpation, superficial palpation. Then when there is nothing, then why do you want to keep doing all this?
Is it you are expected to do that superficial deep palpation in the carcinoma stomach when we are thinking or stomach mass?
Okay,
well done.
Rajavel sir, we are able to hear you.
But I think he's not.
Yes, Jailal.
We are hearing you speaking.
Good evening.
Good evening.
Yeah, yes, I'm listening to the fine.
Okay.
Now, what is slipping away from the examining finger?
You're audible, sir. Very much
Gayatri.
audible.
Okay. No superficial palpable lump, but something is slipping away, it seems.
Yes, ma'am.
What is slipping away?
The distended stomach, ma'am.
We only know lipoma will have a slip sign.
I don't know why you mentioned slipping away.
So it looks you want to put more idealistic thing, but you are not concluding the things.
Exactly.
Then suddenly no guarding or rigidity comes after superficial palpation.
Rigidity is gone or not? Jyoti, I think then what about the back of the abdomen? We didn't hear anything about that. Do you think the abdomen is only anterior abdominal wall or side posterolateral aspect of the abdomen? Is there any swelling in there, the spine?
No,
and
sir.
all?
I mentioned the inspection concern. I mentioned about the flanks, sir, and also
not only flanks. The abdomen is a cylinder.
Tenderness absent where, Jyoti?
There is the back side also. Back part of posterior lateral aspect you have to mention. Sometimes there will be some swelling, maybe secondary. If it's a malignancy, maybe spine secondary, something, or maybe tuberculosis, as you mentioned, is pulmonary tuberculosis. Evident. So all these you should mention the back of the abdomen.
What do you want to see? No mass or no lump?
No mass or lump.
Yes, sir.
What is the mass you will feel in the stomach and what is the lump you are going to feel in the stomach? Stomach is intra-abdominal, no?
Yes, sir.
So intra-abdominal you will feel the lump.
Lump, yes.
Mass or lump?
Lump, ma'am.
Lump.
Then in the breast you will feel what? Mass, huh?
So
So again, we'll have to go to the basic one. What is the swelling? What is the lump? And what is the mass? Is that needed, Jyoti, now? So in the abdomen, you are going to talk about mass or a lump? Mass abdomen or lump abdomen?
Mass.
You understand now?
Yes.
Okay.
Yeah, good.
Okay.
We'll go to the next one, sir.
Yeah, I think he finished his presentation. Now, what do you do for this patient? Okay. You have
differential diagnosis or diagnosis.
Differential diagnosis. Do you have any other diagnosis apart from duodenal ulcer stenosis? Anything else?
Show the picture at least.
Yes.
The picture of the patient. At least we'll have an idea of what we are dealing with.
Yes.
But definitely we are able to see a fullness in that.
There is a fullness.
There is a fullness there. Okay, the stomach is dilated, all these marks also. Okay, so that is the thing. Any differential diagnosis you want to say? Apart from the
mainly, sir, carcinoma stomach, we have to rule out, sir, from our workup, sir, investigation part, sir.
So, what can you define? What is gastric oral obstruction?
Sir, it is mainly the obstruction of the channel that involving the last part of the antrum, sir, and pyloric channel, and the first part of duodenum. The obstruction in that area cause the gastric outlet
So
obstruction.
if it's a pancreatic head mass obstructing the second part of duodenum, you don't call it gastric outlet obstruction?
Yes, sir. It may be, sir, mural or sir, extramural.
Yeah, pyloric antrum, duodenum in general. Okay, do anything beyond duodenum you call bowel obstruction, small bowel. Pylorus and duodenal obstruction you can call gastric outlet obstruction. Sometimes in even pancreatic head mass also chronic pancreatitis can produce.
Yes, sir. Yes, sir.
That is also gastric outlet
Yes, sir.
obstruction.
Yes, sir.
Okay.
How will you evaluate this patient further?
Yeah, how will you proceed?
Sir, we first, sir, do the some basic blood investigation, sir, to look for if the patient is vomiting for last 3 months. So we look for, sir, a complete blood count and the electrolytes, the renal function test, sir. And then,
What
if the patient
electrolyte
has,
abnormality you expect? What is paradoxical aciduria?
sir, electrolyte abnormalities are mainly some hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis, sir, with paradoxical aciduria, sir.
What is the mechanism for this paradoxical aciduria? It's a theory. You know, I am sure you know it.
Yes, sir. Because of the sir, intestinal system activation, sir, there is body try to preserve the sir sodium, sir, and it releases the
Hydrogen ions. Yeah, fine.
hydrogen
Fine.
ion into the
Okay, proceed. What is the next investigation? So you electrolytes you did, then correct the electrolytes. Correct. Then
So, sir, then we will go for a sir upper GI endoscopy, sir.
so you straight away go for upper GI endoscopy. You do the electrolytes.
And
Next same evening you're going to do upper GI endoscopy.
No, sir. We have to firstly prepare the patient, sir. We have to go for Rice tube insertion and gastric lavage, sir. Then we next day we go for sir upper GI endoscopy, sir.
So you need to do base patient is very frail looking. You haven't said the patient is having pallor. Maybe if hemoglobin is 3, you do upper GI endoscopy.
No, sir. No, sir. Firstly, we will stabilize the patient, sir.
Yes,
Initial stabilization followed by upper GI endoscopy. Sir.
any other investigation, any radiological investigation?
Radiological investigation, sir, we can barium meal we can do, sir.
No.
With a gastric outlet obstruction, will you do barium meal? What is the problem you can expect if you do barium meal? Barium study. Nobody does barium. I don't know whether anybody.
Sir, it is not.
Did he mention about barium?
Barium, yes.
Oh.
The barium, first of all, nobody is doing the
We no more do barium, Jyoti.
Yes,
Only for specific cases we go. Yes?
Yes, ma'am. Yes, ma'am.
Barium is an emulsion. What do you mean by emulsion? It's not a solution. It doesn't solve completely. So it's an emulsion. If you give it, the water content will be absorbed, and there's something called barium caking. What do you mean by that? Have you heard of that? The barium salts may precipitate inside the stomach and produce other obstacles. So never do barium studies when you suspect obstruction.
We can go for a CCT hologram, sir.
But what dye you can use if you want to oral?
What are the dye? Yeah, instead of barium, what you can use? That is the thing.
Any other alternative?
Any water soluble. Water soluble gastrography. That's a water soluble dye. It will not produce any precipitation. Okay.
Yes.
If at all you want, I don't think anybody does with the gastric outlet.
Not done.
Don't say that. Don't say that investigation. Okay.
Yes, sir.
Not necessary. Yeah.
We can do some ultrasound whole abdomen, sir, and then we can go for a if there is any finding, sir, regarding malignancy, sir, then we can proceed for sir CCT whole abdomen.
So what is the purpose of doing CCT whole abdomen? What do you mean by whole abdomen?
You have done an upper GI, no? Upper GI after that CT or before that you are doing CT?
You saying before that?
That's the question, yes.
Okay.
Firstly, we go for ultrasound. If in ultrasound we get some findings, sir, then we will go for sir CT scan, sir.
What finding will you prompt you to do CT scan on ultrasound? What finding?
Sir, if there is any extramural thing that compressing external compression is suspected, sir, or there is any chance of metastasis, sir, in the liver, or then we can go for a sir.
So you are now forgotten about entire GI tract. You are thinking of something else.
He's slowly coming back to malignancy, I think now. I think he's slowly.
In our case, what would be the USG finding for stomach particularly, as we are dealing with the gastric outlet obstruction clinically? What would be the ultrasonography finding you expect in this patient? History of 2 years is there. Pardon?
Grossly distended stomach will get, sir.
What else?
Sir, narrowing in the pyloric regions.
Any changes in wall?
Jyoti, we can't hear you. Are you saying something?
Thinning of the.
Hello?
The audio is not proper.
Not
Yes,
proper.
Clarity is not there. What saying?
Which
So,
ultrasound you are done?
ultrasound you do, an ultrasound is saying a sermon, there's hugely dilated stomach,
Yes,
maybe
sir.
narrowing of the pylorus, and no
Yes, sir.
other findings is there. Liver normal, ascites is normal,
Yes, sir.
not there. Nothing is there.
Yes,
What
sir.
do you do
Yes, sir.
next?
Here in this case, you have a difficulty. You know, no mass. You are suspecting a GI tract. Any other ultrasound you can do?
I wanted to ask, sir.
Endoscopic ultrasound we can do, sir. Endoscopic ultrasound we can do.
See, during
Endosonogram.
endoscopy, what all findings you look for? What will you look for in endoscopy? You've done an, after that you prepare the patient, stomach empty, stomach was given. You put the scope in. What are the points you look for in endoscopy in gastric outlet obstruction? What are the
Firstly, we look at the stomach, sir, the distension of the stomach. Then we look for
distensibility of stomach, is it?
distensibility of the stomach. Then, sir, we look for presence of any ulcer or any growth in the stomach, and we look for the scope negotiation to the duodenum, sir.
Okay. So you should look for this any ulcer or malignancy, any ulcer lesion. If the
Yes, sir.
ulcer is there, the relationship with the gastric outlet as well as the GE junction, you have to look for. Suppose
Yes,
there's an
sir.
ulcer, the malignant ulcer in lesser curvature close to the pyloric antrum.
Yes,
How
sir.
much distance it is from the
GE junction we have to
GE junction
look,
is very important for the management.
Yes, sir. Yes,
So
sir.
distensibility, distance from the pyloric antrum and the GE junction
Sir.
and gastric outlet obstruction.
Yes, sir.
Then how many biopsies you should take if there is an ulcer? Benign ulcer.
Sir, 6 to 8 biopsies should take, sir.
Minimum 6. If
Why
more
not
the number,
more?
Ideal is 10. Ideal is 10. 10 biopsies.
the more you take, the more will be that.
More will be the results. Yes,
What is well biopsy?
Well biopsy, WEL, well biopsy.
Suppose you see no ulcer, no expecting some thickening, when suspecting a linitis plastica or there is something else is there, you can deep biopsy you are going to take.
Okay.
The mucosa is normal, then we can go for a well biopsy.
You already mentioned
Got it?
generalized lymphadenopathy
Yes,
with a
yes,
lymphoma. What is the plane of lymphoma you get? With which plane you get the lymphoma lesion in stomach? Among the layers of stomach. Is it
Lymphatic, lymphoid tissues are there in which layer? We have mucosa, submucosa.
It is definitely not mucosal, isn't it? Submucosal. So you may need this.
Submucosal.
Can you say another lesion in the stomach which is more submucosal or muscular propria? We can produce a mass in the stomach. Common thing.
External, extraneous compression.
Gastrointestinal single tumors.
GIST also. Yeah. In these conditions, you may need a well biopsy, deep biopsy.
Yes.
Mucosal lesions will be more superficial. You may take a biopsy. It's a normal forceps. Okay.
Yes, sir.
So you do it.
The scope is negotiated into the duodenum. So now you think it is a benign. Suppose in a malignant condition, there are maybe conditions where you can negotiate up to the duodenum. Some condition you will not be able to negotiate. What is the difference? What is it going to give you the value? remember always, if you can negotiate to the duodenum, the nutritional deficiency of the patients will be less.
Less.
But in your patient, you say in a general examination is very poor nutrition. And what is the problem then? There is no complete obstruction. The tube, up to that, your tube is able to go in. Why is getting all this nutritional deficiency?
Scope not negotiated to
Not
duodenum.
negotiable.
Not negotiated.
Not
sir.
negotiated. Okay.
Not
Not
negotiated. sir.
Yeah.
Not negotiated.
Sorry, I this covered.
Complete obstructions.
So there was no lesion, no ulcer, nothing was there. Only thing is there was a stenosis at the duodenum.
Stenosis. Yes, sir.
Where was the stenosis? Pyloric stenosis.
Pyloric stenosis, sir.
So it's not a duodenal ulcer stenosis.
Pylorus is a part of stomach or duodenum?
It is not a
Stomach,
duodenal ulcer stenosis. You said pyloric stenosis. So what is it due to? So duodenal ulcer cannot produce pyloric stenosis, no?
It is a problem in the duodenal cap. It is going to be on the not with the pylorus.
Not with the pylorus. So I think is it
But, sir,
huh?
in the CT scan, sir, I am mentioning that the thickening is in the pyloroduodenal region.
No, you mentioned in upper geoscopy here. Pyloric
Yes.
stenosis. Upper geoscopy only you written.
Upper G endoscopy, sir, mentioned it is as pyloric stenosis, but in the CT scan, they have mentioned that pyloroduodenal thickening, sir.
No, which is more the one
is more reliable.
More reliable. You are directly visualizing
Endoscopy, sir. Definitely endoscopy, sir.
Yeah, endoscopy. That is more reliable. So there is thickening at the pyloric area, isn't it? Pyloric stenosis is not a duodenal stenosis. So what else it is? Is there any lesion there? You would now if you want the sir and my madam mentioned about one more other investigation, you can add on to that. You can find out if there is any mass there. What are the investigation? Endoscopic ultrasound, no? Any thickness, any mass lesion in the pyloric region.
Yes, sir.
It is a deep-seated or something, fibrosis or anything. All this you can pick up. So it is definitely not duodenal stenosis according to this endoscopy report.
Is there something called laparoscopic ultrasound, Jyoti?
Yes, ma'am.
Yes. Is it useful in the case of stomach? What do you want to know?
Laparoscopic ultrasound. Stomach. Don't know, ma'am.
Laparoscope can also do an ultrasound, no?
Yes, ma'am.
Yeah, for liver lesions, that is more useful.
Most more useful.
Okay.
Will you do
Yes.
laparoscopic evaluation? Suppose you suspected malignancy here. When will you do a laparoscopic diagnostic laparoscopy? You can
Diagnostic laparoscopy.
Laparoscopy. What are the indications to do diagnostic laparoscopy? In stomach, carcinoma stomach, suspected carcinoma stomach. Not suspected, proven carcinoma stomach.
This proven. And you
proven carcinoma stomach.
Usually, sir, above, sir, stays above T2, sir, we really go for
T3 and T3 and more.
T3.
TCN they will say T1B and more, but T3 is the more accurate thing.
Yes.
How to do a laparoscopy? What all things you look for? Diagnostic laparoscopy.
Diagnostic laparoscopy, we look for, sir, we look for, sir, any hepatic deposits, also carcinoma peritoni, sir.
Suppose there is no nodule, no peritoneal deposit, there is no ascites. How will you further assess? Is there any other method of assessing the metastatic status? There is something called lavage. Have you heard of that? Peritoneal lavage?
Yes, sir.
Yeah.
We can give a lavage and send the sample, sir. Yes, sir.
Yeah, you can do cytology and
Yes,
it's not well accepted. Now it's getting
Centrifuge and then
you can study the cells. Okay. Cells are positive, it's considered as a metastatic disease.
Yes.
So if it's metastatic disease, the management will change. Okay. So that is the thing. So CCT, you said CCT. What all things you look for in CT? Which all areas you look for? Suppose if there is a thickening in pylorus, you're suspecting malignancy. Suppose the biopsy taken is to malignancy only. What CT will do? Pylorix malignancy without gastric outlet obstruction.
We look for the sir lymph node involvements.
You do only abdominal.
Lymph node.
Yes, sir. Kamlesh, you want to say something, Dr. Kamlesh?
No, actually, you think in terms of staging. Now already proven malignancies there on biopsy. Now you think as a clinician, what you for planning of the management, how will you look for staging?
You do only abdominal CT?
No, sir. No, sir. We will do a CCT thorax also, sir. CCT thorax, thorax, sir. Thorax.
Thorax, abdomen, and pelvis. That should be the scan.
Yes, sir. Yes, sir.
So what will you look for in CT?
Sir, we look for the regional lymphadenopathy, then involvement of other solid organ, then sir, involvement of involvement of tissues, sir.
So easiest thing is you can think about tumor, node, and metastasis. Tumor act as like involvement. Other organs you have to specify which organ.
Liver, sir.
Liver. Direct T stage will involve liver more or
No,
any other one?
no, sir. It may involve the colon also, sir. Transverse colon.
Transverse colon, transverse mesocolon. Pancreas is the most common.
Pancreas, sir. Yes, sir.
The nodes and metastasis, lung, everything. Okay.
But
so now, do you have a final diagnosis here? After endoscopy, again, we are confused. You said pyloric stenosis. And we can't accept the benign thing now here anymore because the pylorus is stenosed. What is the diagnosis? Final diagnosis?
Final diagnosis, sir, as the H. pylori are also come out to be, sir, positive, sir, in this case, sir. And we are unable to negotiate the scope to the duodenum. So we cannot say, sir, the duodenal ulcer is present or not in it may be present, sir.
The pylorus, again, is written here also, pylorus is grossly narrowed. So it is not duodenum. So you have to suspect more than that. Sometimes there will be stenosis of the malignancy and the growth will be beyond this malignancy, the stenosed area, isn't it? So in this case, in my opinion, we need to rule out malignancy definitely. Patient's general condition was that of a malignancy, and the endoscopy report is also supporting the possibly a malignancy with stenosis, proximal stenosis, and the actual lesion may be little distal. That's why you are not able to negotiate into the actual. You are not seeing the mass. With this endoscopy report, we cannot entertain a benign duodenal ulcer stenosis. I don't think. Because it looks, you have to really look for a malignant stenosis of the pylori.
Okay, sir.
Yes, sir. So that is a fine thing. So suppose you want to do, how will you further, how will you get a biopsy now? Suppose there's a lesion you want to see, you can do CT, you can do the endoscopic ultrasound, that will give a clearer idea whether there is a mass or thickening of the pylori.
CT done, sir, already, sir. CT done, sir. CT shows, sir, grossly distended stomach with thickened pyloroduodenal junction, sir.
Yeah, again, 75 thickened pyloroduodenal junction. So there is something there in pylorus region. So there is definitely a thickening. The hugely dilated stomach you can see.
There should be something that has not been picked up.
Yes.
Yeah. Something is missing.
Stomach
Something
is so much.
Jyoti,
How
have
do
you
you
heard
measure the
about
thickness of the stomach? How much is thickness?
Sir, they have not mentioned, sir, about the thickness. They just mentioned that there is thickened. Yes.
They will not mention Jyoti. We are supposed to ask.
We have to ask.
Whatever you want, you are supposed to ask them. Only then they will tell you. Okay?
Yes, sir.
Do we expect in a benign condition, the stomach wall is going to be so much thickened? Such a dilated stomach?
Dilatation may be there, sir, but thickness not be there. Sir.
Dilatation, thickness more than 2 millimeter.
Jyoti, what is adult
Thickening
hypertrophic
the
pyloric
CT, you have
stenosis?
a doubt, you know.
Yes, ma'am.
Thickening seen in CT is significant. Yes, Jyoti?
Yes, ma'am.
CT just shows thickening.
Yes,
Aren't you worried or not? Yeah.
Yes, ma'am. Yes, ma'am.
And also other
Okay.
features are
What
also
other
subjective of
investigation will you do?
malignancy, Jyoti. It is not a your general condition. If all these are there, it is not looking like benign. So there's a thickening. So definitely we have to further evaluate this patient. Biopsy may be difficult because
You should
maybe
have asked about nodes also.
you may not be able to negotiate into the actual
sir.
area. So you may find it difficult. So how will you do? I can do other modalities like if you can get endoscopic small thing, biopsy,
Endoscopic ultrasound.
guided FNAC, something like that. You
Yes,
can
even
try.
guided FNC you can try, sir.
Difficult. Maybe the whole tumor, whatever will be, that. Maybe it's sometimes difficult. What will you do next? So CT is showing a thickness.
Jyoti, my question is, can pathoradionomics play any role here? Pathoradionomics with use of artificial intelligence. You are not able to negotiate the scope. You can plan 3D color virtual CT endoscopy and you try pathoradionomics. Just a question. Is there any role nowadays?
Virtual CT role is there, sir, in obstructive lesion which
it is a kind of combination of radiology and pathology
yes,
with
sir, yes.
AI tools which can pick up malignancy in some cases, not in what just on theoretical ground only.
Yes.
Sir is talking about the new terminology given, that is virtual biopsy.
Virtual biopsy.
Yes.
Jyoti, have you heard about adult hypertrophic pyloric stenosis?
It is due to hypertrophy and hyperplasia of the pyloric circular muscle, sir.
Yeah, is it a diagnosis or not? Because you are not seeing any ulcer there.
Yes, sir.
There is definite pyloric stenosis is there.
Yes, sir.
Wall is
Yes,
thickened.
Yes, sir.
So you can think about the adult hypertrophic pyloric stenosis.
Pyloric
Like we have the
stenosis.
infantile.
Okay, sir.
Similarly, you can have
Okay,
the
sir.
adult
Yes,
one.
sir.
Adult
Yes, sir.
hypertrophic pyloric stenosis. Yeah.
Yes, sir.
Okay.
Yes.
Now, how are you going to further evaluate this patient? How will you do? What will you do now? There's a confusion. Adult pyloric stenosis, malignancy pyloric antrum stenosis, thickened stenopylor. So you have to malignancy. If it is there, you have to give the advantage to the patient. You can't just treat it as benign, no? So what will you do?
Sir, we can go for some biopsy, sir.
How will you take biopsy?
So we'll
Scope is not getting beyond the pylorus.
yes,
No,
sir.
there is a
Yes,
tight
sir.
stenosis of the
Because
pylorus.
the patient is having distal complete obstruction, so we have to go for a management, sir, immediate surgical management, sir. So if we go for gastrostomy in this case, and then we can take out the involved part, sir.
Now, what do? You gastrojejunostomy.
And distal gastrectomy we can go for.
Most of the time in a benign condition, the scope is not passing. It is due to the edema, and there is a. So if we can once again prepare the stomach because so much distended, give rest, give fluids, prepare the stomach, and you can once more attempt
Yes,
to do the
Or
endoscopy
you
and
see
see.
something called a pediatric scope. Small scopes are available. Maybe a small
sir.
scope. You
Yes,
can
sir.
try to negotiate and see if you get a biopsy. If some lesion is there, I'm not saying there is some lesion.
Yes, sir.
If it is not there, good for the patient. If it is there, you should not miss. Or another option will be a laparoscopic attempt. You can see a laparoscopy and see the lesion. So there may be some thickening from outside. If you can take some laparoscopy, ultrasound guided FNAC, something like that.
Okay,
That
sir.
is another option. Okay. Just to rule out any malignancy. Purely benign treatment will be easy. If it is a malignancy,
Any tumor markers you can do, Jyoti? He's not there.
Yes, sir. Here only, ma'am.
Okay.
okay, now suppose it's a
Tumor
benign
marker.
thing. What are you going to do? Benign. Now let us stick to your diagnosis. Malignancy also, I think we may not get time to do a lot of things.
He doesn't want to discuss that. Yes.
Yeah, malignancy doesn't want to discuss also. Benign. Okay, you ultimately turned out to be a duodenal stenosis with a stenosis of the, though it doesn't look like that anyway.
Yes, sir. So it is if it is due to benign peptic ulcer, chronic peptic ulcer disease, sir, then due to the obstruction, we have to go for sir Roux-en-Y
No, we are
gastrojejunostomy.
talking about this patient. If there is obstruction, there's nothing. If there is obstruction, isn't it?
There is obstruction.
Then we have to go for sir gastrojejunostomy, sir.
Yeah, your patient also. The
Gastrojejunostomy, sir.
only gas. What can you specify complete treatment? This only gastrojejunostomy. Can you give the adjectives
So
for
no, sir,
gastrojejunostomy?
we can go for Roux-en-Y gastrojejunostomy followed by sir testing is positive in this patient and 4 to 8 weeks of PPI followed by sir till eradication.
So if you do only Roux-en-Y gastrojejunostomy,
No,
this
no,
patient
no.
diagnosis,
We have decided
That
for
is
surgery.
totally inadequate. That is symptomatic
No.
treatment.
not inadequate. You do think
No,
the
we have
patient
decided for surgery now. So what are you going to do? What is the cause, etiology for your duodenal ulcer?
The hyper-acidification, ma'am.
Aren't you going to treat that?
So you will do only the gastrojejunostomy. So you will get an next after 1 year you get an anastomotic ulcer, isn't it?
What, sir?
If you do only
Yeah.
gastrojejunostomy, the ulcer will come back at the anastomotic site. So what do you do? Madam is asking, what is the cause for all this? Will you don't treat the cause?
We can go for truncal phlebotomy, sir. But
We can
nowadays,
do
sir,
some. You have to do. If
Now,
you're doing
now,
gastrojejunostomy, you have to do.
now, so is it something better than truncal vagotomy?
Any other types of vagotomy? Is there anything better than truncal? Anything else?
highly selective phlebotomy is there, sir.
Highly selective.
Dr. Bhattacharya.
What is the
So may I
advantage
come
of
in,
highly
please?
selective or truncal vagotomy?
Sir, in
Dr. Bhattacharya.
yes, sir.
What is the difference?
Look, in this case, or any adult having this kind of pyloric stenosis, you have to rule out malignancy.
Yes, sir.
So you will have to take a sample. You'll have to excise the pylorus
Yes, sir.
and send it for histopath. It's
Yes,
not
sir.
necessary that you're just taking endoscopic biopsies will prove that it is benign,
Yes, sir.
right? So
Yes,
any surgery, you will have to remove this portion, the offending portion, and send it for histopath. So just doing a bypass with vagotomy and all will not help.
Yes,
The
sir.
patient may turn up a few years later with malignancy. And then
Yes,
what?
sir.
Yeah, correct.
Mm.
Sometimes
Yes,
the rare tumors like neuroendocrine tumors and all those things can happen. It's not maybe not adenocarcinoma. We have seen 1 or 2 cases like that. Some professor said. So you need to
That's what
always,
he said, exploratory laparotomy initially. So
What,
maybe
ma'am?
he will decide on table.
yeah, that will be better option.
No. I mean, deciding on table is not the question.
Guys, with
He has
the
to go with
advent
the
of investigation, we have the term exploratory laparotomy cannot be used. We
Right.
have a laparoscopy. You have a lot of things with you.
Laparoscopy and the laparoscopic ultrasound facilities there, you can diagnose almost completely. You can do the investigation prior to that and see the thickening, everything. You can decide prior, then decide and go. There is thickening, definitely is better to give the benefit of doubt to the patient rather than doing just that.
Yes.
That is the best thing. Okay, benefit of doubt.
Even for a benign condition, we can the duodenectomy or the pyloroplasty is so possible. You can do the pylorectomy and then do the anastomosis. Bulrath you can go.
Antrectomy, like no, there's antrectomy will be a treatment for the duodenal ulcer also. Antrectomy, the
So
best
before
treatment.
we operate, we'll have to know whether it is benign or malignant.
Yes, ma'am. Yes, ma'am.
So treatment always we may have to excise the pylorus. That is one thing.
Ma'am,
Benign or
Dr.
malignant.
Bhattacharya. Hello.
Yes, yes, sir. Yes, sir.
Hello.
Yes, sir.
Yes. Yes, sir. Who is that?
Your voice is not clear, sir.
Hello,
So
I am
what
Dr.
is
Rajavelu
PV ring?
here.
Hello.
What is PV ring, Jyoti?
Ma'am?
PV ring. You're talking about gastric genostomy, no?
Hello.
No.
So what about, just explain about this GJ you're talking about, gastric genostomy.
What
How
are
will
the
you do?
you didn't completely say that. The older, maybe no new terminology, it may not be relevant. Which wall you do the GJ better in a benign condition, where will you do the GJ? Anterior wall or posterior wall?
So we'll do the posterior also.
Posterior. It's more physiological. Okay. What are
Yes,
the
sir.
other adjectives you should use for GJ for benign gastric outlet obstruction?
It should be, sir, isoperistaltic, sir. And we
Yes, good. Isoperistaltic.
retrocolic
Why it should be isoperistaltic? Because you are doing vagotomy. You mentioned vagotomy. No, vagus is the secretomotor fiber, secretion as well as the motor to the pylorus. That both are gone. So the gastric outlet emptying will be affected. The motility of the stomach may be affected. That's why it should be isoperistaltic. The peristalsis of the stomach should be in
Drainage
line.
procedure, that is secondary.
That's why posterior wall also.
Secondary to the actual pathology.
Okay. Then also we can do a short lobe retrocolic isoperistaltic.
Yes,
These
sir,
are the other
retrocolic.
adjectives. Okay, retrocolic. Okay. Have you heard of endoscopic GJ? What is an endoscopic gastrogenostomy? Can you do endoscopic GJ?
Yes, sir.
Nowadays, people have
Yes, sir.
started, gastroenterologists have started doing endoscopically. What do
Yes,
you,
sir,
how
I
you
can-
do it? Any idea? Any idea? They do with the endoscopic. Then they put a balloon into the jejunum and inflate it and identify the balloon with endoscopic ultrasound. Then penetrate with a guide wire and they do lamps. What do you mean by lamp?
Sir, lumen occlusive metallic stents.
Lumen opposing metallic stent, isn't it? That they put between the stomach and the jejunum. They started doing it. So it will be little minimally invasive. Patient need not undergo any surgery, even not even laparoscopy. That is also. But if tight obstruction is there, it can't be negotiated. Okay.
Endoscopic magnetic GJ is also being done
Magnetic
nowadays.
yes.
In early phase now.
Sir.
Magnetic
Yes, sir.
gastrostomy.
Can't you do only endoscopic dilatation?
Yes, sir, we can go
Balloon
for
dilatation.
Standing dilatation, sir. We can go for and endoscopic stenting.
You go for stenting in the proximal part of the stomach or distal, which is better? The cardiac end or the pyloric end? Stenting, which is better? We often go for the proximal one. Of course, you can do for distal also, but the proximal is commonly done. Okay.
Okay.
So you have to be careful when you do stenting in the lower end because it should not extend to the D2. You can block the bile duct drainage. If there is any obstruction to the bile duct, there will be jaundice. So if you suspect that, always stent the bile duct also. Put a stent to the bile duct, then only stent the pylorus and the second part of the duodenum if you want. Okay. Duodenal stenosis also. That's all.
In early disease, you can do plain only endoscopic dilatation also. That can be work. But these kind of stents, it will not work. You have to go for some definitive procedure.
Yes.
If it's only tight stenosis, there is something called endoscopic incisions. Incision, you can make multiple incisions in the pyloric area or duodenal stenosis incisions. Then you can do balloon dilatation. Sometimes it may work. Then, but there's definitely a risk of perforation. If you do the forcefully dilate it can perforate. So surgical option will be better. You can very tight and a highly fibrotic lesion, it will not work. Early stenosis and or balloon dilatation will work. Plus or minus stenting. That will be an option early stages. After excluding malignancy, if it's operable. Okay. Suppose malignancy, do we have 5 minutes more or we can, is it time to stop, sir?
We'd like to close by 10 o'clock, sir. You still have time.
Tell time. Okay, okay. So suppose now benign condition, we need to. What are the other options for benign condition? One is truncal vagotomy. You said.
Sure.
What is selective vagotomy?
Sir, in
Highly
selective vagotomy,
selective.
vagotomy, sir, we spare the celiac branch sensor hepatic branch, sir. And in highly selective, sir, we preserve 7 centimeter from the pylorus, sir, and we all the of methods it will stop, sir.
Yes, around 5-7 centimeter proximal to pylorus is stopped so that the pylor motor fibers are spared, isn't it?
Yes,
So
sir.
no need
Yes,
for
sir.
drainage procedure. But the
Yes,
problem is there will be more recurrence of the ulcers.
yes, sir.
Both selective and high truncal vagotomy, we are devascularizing the pylorus also. So you need a
Yes, sir.
drainage procedure.
Yes.
So, but the
Yes.
recurrence of a highly selective is more than
Yes, sir.
compared to the other two. Okay, right.
Yes.
Then antrectomy is another procedure we can do. Antrectomy with the truncal vagotomy has the least
Yes, sir.
amount of recurrence.
Yes.
Compared to the various anti-ulcer procedures, antrectomy combined with truncal vagotomy is having the least amount of recurrence, less than 1% or something. Okay. Others are also 10%. Highly selective is around 10%, which is a very unacceptably high rate of recurrence of the ulcers.
Yes, sir.
Okay. Have you seen highly selective vagotomy?
Highly selective, not selective. Truncal
It is
vagotomy, yes,
basically
sir.
the devascularization of the lesser curvature, both anterior and posterior fibers. So, you can small vagal fibers, it may be difficult to find. They may follow these small branches of vessels. So you have to ligate the entire small branches of the vagus going towards the pylorus.
Yes, sir.
Suppose turns out to be malignancy, pylorocanther, and CT is showing. CT can show you 3 pictures. One is the operable, not locally infiltrating, no metastasis. Number 2, it is locally infiltrating, but no metastasis. Number 3 is a metastatic disease. How will you manage these 3 conditions? Operable. No local disease, no locally pancreas and mesocolon not involved. No metastasis, no ascites. Only there is a isolated pyloric malignancy, adenocarcinoma.
Sir, in T1 disease, sir, we can go for, sir, endoscopic resection of the.
See, one thing you should remember: whenever there is an outlet obstruction, it cannot be T1 lesion. Okay.
Yes, sir. Definitely.
If a lesion has produced obstruction, it is definitely more than T2, T3.
Yes, sir.
Yes, even lesion will not produce outlet obstruction. Even in esophagus, it comes as absolute dysphagia. That means it's more than T3.
Yes, sir.
T1 lesion will not produce. Okay. So this is beyond that endoscopic mucosal resection stage. It's already produced outlet obstruction.
Yes, sir. So we go for a distal gastrectomy, sir, with distal gastrectomy D2 lymphadenectomy, sir.
What do you mean standard gastrectomy in Japanese classification? Standard gastrectomy means what?
Standard gastrectomy
You
means, sir,
remove 2/3 of the stomach, minimum 2/3 of the stomach with the
yes,
D2
yes, sir.
lymphadenectomy. Okay.
Yes,
So
sir.
this will be distal gastrectomy, 2/3 of distal gastrectomy. What will be the margin you would look for? Stomach.
Sir, sir, proximally, sir, 5 centimeter margin should be there, sir. And distally, the margin is, sir, 1 gram, sir.
Distally, you can't say, maybe close
Yes,
margin
sir.
only,
Yes,
maybe
sir.
negative margin negative.
Yes, sir.
Proximally, 5 is standard,
5
but
centimeters.
early lesions as in T1 or early T2 with
Yes, sir.
expanding type of Borman classification, not infiltrating. You can do 3 centimeters, okay. But as a standard, you can say 5 centimeter proximally.
Yes, sir.
5 centimeter proximally. And then what do you mean by D2 lymphadenectomy?
D2, sir, removal of lymph sir, station 12, sir.
Sorry?
Removal of lymph station 12, sir.
Station 2. Which are, you know,
12,
the left
12, sir. 12, sir. 12, sir.
12A, with 12A, okay.
Yes.
But that is all the stations are taken 1 to 12A? See, distal gastrectomy, generally
Yes, sir.
you don't have to take a level station 2 and station 3 SA, that is short gastric, and left cardiac nodes you will not take because that's far away from deletion.
Yes,
And
sir.
station 10, that is splenic hilar nodes, are not included in the D2 gastrectomy. Anywhere may be deletion. Okay. So except these 3 nodes, all the nodes are taken in a standard D2 lymphadenectomy. Distal. If it's proximal total gastrectomy, level 2 and 3A are also taken.
Yes, sir.
12A only. 12 is very hepatoduodenal ligament, isn't it? A means hepatic artery. B and P is also there. B is the bile duct and P is the portal vein. These two are not part of the stomach, so we don't dissect that. Up to 12A only. So the answer will be standard gastrectomy with a D2 lymphadenectomy. That will be the answer for distal stomach. Will you do the bursectomy, distal pancreatectomy, splenectomy? These were all part of the original D2 lymphadenectomy. Will you do that or not? Have you heard of that? What do you mean by bursectomy? Bursectomy means the removal of the stomach, the entire omentum, the lesser omentum, the omental sac, pancreas, the anterior layer of the mucosa colon, as well as the pancreatic capsule. But that is not done these days, not necessary. Also, distal pancreatectomy and splenectomy is not part of the distal D2 lymphadenectomy. Okay. Now, the second scenario, suppose locally infiltrating, what you do? Pancreas is infiltrated, T4 lesion to the pancreas, no metastasis.
Yes, sir. So we can go for, sir, neoadjuvant chemotherapy.
Yes. Do you know some regimes?
Sir, we can go for tocilizumab, oxaliplatin.
No. You can do the capoxis nowadays there, but the best regime is float regime. Float
regime, sir. Yes, sir.
Float regime. So after the chemo, you can reassess with CT.
Yes, sir. Yes, sir.
Then think about surgery if possible.
Yes, sir.
Will you go for a compound resection of this pancreas? Suppose after chemo, still some infiltration. Will you go for resection of the mesocolon with colon or pancreas along with stomach? What is the criteria for doing that? You can do, provided you can get an R0 resection.
R0 resection.
For debulking, you don't do. Okay. So that is the second scenario. Third scenario, already the patient is having metastatic disease. CT showing multiple liver nodules or ascites or peritoneal deposits. What will be your plan of action in this patient?
Yes, sir.
In this patient, again, I must tell you, before you send the patient for chemo, you should do something for the gastric outlet obstruction. Because already this patient is having a goo. You can't just send for chemo. You have to do either a stenting or a GJ and send the patient for a. Otherwise, patient can't do. Okay. So do something and then send for chemo, then reassess and okay.
Yes, sir.
Suppose a metastatic disease.
Metastatic disease, sir. We can go for palliative treatment, sir.
Yes. What do you do palliation here? What palliation?
Mainly, sir, we have to go for the bypass, sir, for symptom relief, sir, or placement of the stent, sir.
Yes.
Yes, sir.
Yeah, bypass of the obstruction, isn't it? Gastrojejunostomy. Okay, gastrojejunostomy and send for chemo. The patient will be hopefully have a metastatic disease. We may not reconsider any curative intent surgery later also. So these are the three scenarios you think about: operative, operable, or locally infiltrated, or metastatic disease. Sir, I think we will. Any Kamlesh, Dr. Kamlesh?
Yes, sir. We can wind up, sir.
Okay.
So, Dr. Bhattacharya.
Yes, sir.
You've done well, sir. Any comments on his performance, sir, Dr. Haridas?
Yes, I think he's done well. He has presented very well. Only thing I advise is he's mentioning too many unnecessary things in the clinical presentation.
So anything not okay should be opted out to mention.
Okay, sir.
You should expect question on whatever single word you utter in the exam. So be prepared for it. Okay.
Okay, sir.
Otherwise,
Sir.
it was good presentation. Nice.
Okay, sir. Thank you, sir. Thank you so much.
Dr. Jyoti Prasad Bhattacharya, do you have
Yes,
any doubts, any questions for the examiners?
Yes, sir. I have one doubt, sir. Like now with invent of sir, HP pylori Helicobacter pylori eradication therapy and sir PPIs, then why we are going for the phlebotomy procedure in this patient, sir? Why after gastrojejunostomy we can go for that pylori kit and followed by PPI, sir?
Dr. Haridas, sir, could you?
Okay, so I think he's asking you why should you go for truncal vagotomy in a GJ procedure? Is it? Is that the answer?
Yes, sir.
Okay, see, this patient is already, suppose it's a duodenal stenosis. You must have been treated with PPI. One of the indications, suppose you get a complication like duodenal perforation on table. Okay, the indication for doing a definite stage surgery is one, patient has perforation on PPI. Suppose patient may be on PPI perforated, or patient's taking some NSAIDs or something, which he cannot stop. So this patient has already developed such a tight stenosis, which it will be always better. You are doing a surgery. It's always better to do a more definitive control on the acid secretion. Otherwise, what will happen? No, there will be something called anastomotic ulcer. The hyperacidity inside. Hyperacidity inside can produce ulcers around the anastomotic surface of the jejunum, which will be more troublesome. So, if you're doing a GJ for duodenal ulcer perforation, it's always better to combine it with the truncal vagotomy plus anti-PPI, anti-H. pylori treatment. What will be the association of duodenal ulcer with the H. pylori? What will be your assessment? How many percentage of duodenal ulcer is associated with H. pylori? How many percentage of gastric ulcer associated with H. pylori?
Duodenal ulcer, sir, association is around 70?
No, it's more than that. Around 92% of the duodenal ulcer and 85% of the gastric ulcers. There is definite association with H. pylori. So you can give anti-H. pylori treatment plus a definitive surgery will be a better option. Like because already patient has got complications. That's all.
Yes, sir.
We don't want to take another step. So always do a truncal vagotomy and BJ will be better option.
Yes. Yes.
The only thing that can be done endoscopically is now what they do is poem for esophagus. It can be done for the stomach also. G poem, that is what they say.
Okay. Okay, sir.
Especially in gastroparesis cases, like
Yes, sir. Yes, sir.
gastroparesis, motility disorders.
Yes.
This is not a motility. This is actually a obstruction is there. Sometimes there will be motility disorder which produce gastroparesis. So you can do G poem, like a poem they do. Someone can do the G poem. Correct.
Yes.
Right. Anything else? Anyone would like to comment on? If not, then we'll call it a day. Thank you so much, sir, everyone. Thank you for giving your time.
Yes.
And it was a lovely discussion.
Thank you, sir. Thank you, sir.
Dr. Bhattacharya, you've done very well. So
thank you, sir. Thank you so much.
You brought a lot of knowledge out from the examiners. It was a big thing for us. Thank you so much. Good night, everyone.
Okay, thank you. Good night.
Good night, sir.
Kanagavel?
Sir is not here. I'm in charge of tonight's show.
Okay.
Oh, Rajiv sir, I am Dr. Rajavelu from Vellore.
Yes, sir.
I joined a little late, sorry. But
sir,
yes, I just wanted to add only one thing. Yes,
sir.
Because I think the presentation was good, discussion was very good. Only thing is, whenever the PGs during examination, they are a little confused about benign and malignancy. They're not able to switch over. Even after hearing all discussion from you, they are sticking on to the same diagnosis, same discussion, prefixed ideas. I think they have to. Okay, I think they must know to flex.
Yes.
Jyoti, well done, Jyoti. I think that is the only thing I wanted to put it in.
Yes.
Right.
It
will be always better.
So I don't think he could have talked about the benign condition in this case, and he could have stick on to the carcinoma stomach and discuss about that. That will be much safer for your side.
Safer for you.
Yes, sir.
I think at every stage, Dr. Hari was giving clues that it is more likely to be malignancy, but he's not picking it up. and the direction he kept on towards the benign only.
Jyoti,
fact, it
sometimes
is-
even ultrasound or CT may prove it is a kidney, but if the clinical finding shows it is a spleen, you have to talk only as a spleen. That is what
Correct.
it's only a clinical
Correct.
examination.
Yes,
So
Correct.
what you
Correct.
have.
Correct.
And it
Yes,
is always
Yes,
better to
sir.
err for malignancy rather than benign, even in
Yes.
real life, than
Can,
Yes.
the
true.
other way.
And
True.
in
And
this
also,
era,
duodenal obstruction
in
is
this
very,
era,
very
it's very
rare.
difficult.
You don't get
in this,
duodenal obstruction and all, isn't it? So always
even
better.
hypertrophic pyloric stenosis of an adult. I mean,
No.
yes, sir. Very rare.
Very rare. Very rare.
Very rare.
All the best, Jyoti.
Yeah, thank you, sir. Thank you so much.
but
Okay,
you are
thank you.
you are a wide read
Amit.
and you want to say everything in a case. That is only. You should
Okay,
stick
sir.
on to
Okay.
that. Be simple. We are not expecting a high five from you. If you are stick on to basic and what you are seeing, you are able to express. You can easily go through because you have read a lot. You have knowledge, but only practical application. Little more you have to tailor make.
Okay, only
you, sir.
a commonsensical approach. When you see the pyloric stenosis, all thickening and all, think about more common conditions rather than
Yes,
sticking
sir.
on to your. Okay, that's the only thing. Otherwise, you've done well. Jyoti. Okay.
Yes,
So
yes. Thank
sometimes
you, sir.
what happens that students gets biased when they know the exact investigations and exact diagnoses. So they get biased. That's the only problem.
The retrospective analyzing of the case, that's what's
Yes.
happening. They've
That's
seen
the
all
point.
investigation and
That
going
is
back.
always a problem.
That's
Yes, sir.
Right. So then, in a nutshell, the candidate should always perform or say whatever they do in the wards and in the OPD rather than what is said in the books. Because what you do in the wards and the OPD is always the best way to present your case.
Yes.
Thank you so much, everyone. Good night.
Thank
Thank
you.
you. Good night.
Thank you.
Good night, sir. Thank you.
Good night, sir.
Thank you.